Hello and welcome to the Radiology Scholars Certificate Program. My name is Nick Cantillo. I'm an MS4 at the Wake Forest School of Medicine, and this video will be covering CNS infections, a localization-based approach. This will be part 2 in the series. I'm covering intraaxial infections. So in the previous video, we covered extraaxial infections, those involving the epidural space, subdural space, meninges, and ventricles. Here we'll cover infections of the intraaxial compartment, which is more involving the neural elements, such as the cerebrum, the cerebellum, and the spinal cord. So we'll begin by covering infections of the cerebrum. This includes entities such as cerebritis, encephalitis, intracerebral abscess, intracerebral mycotic aneurysm, and infectious CNS vasculitis. So we'll begin by discussing cerebritis and encephalitis. These are somewhat similar terms that are used in varying contexts. Cerebritis is used in the context of brain parenchyma inflammation resulting from lupus, as well as bacterial infection of the brain parenchyma. In contrast, encephalitis is used in the context of viral infection, is used in the context of post-infectious inflammation of the brain parenchyma, as well as paraneoplastic processes. Pathogens implicated in cerebritis tend to be listeria and other meningitis-causing organisms, whereas for encephalitis, we see herpes viruses and mosquito-borne viruses. Pathophysiology involves either the contiguous or hematogenous spread of the pathogen to the brain parenchyma, causing inflammation, which can impair the permeability of the blood-brain barrier and puts the patient at increased risk of complications such as hemorrhage, as well as abscess formation in cases of bacterial cerebritis. Imaging findings, best seen on T2 flare sequence. You'll see gyro hyperintensity and edema. In HSV encephalitis, this is classically seen in the temporal lobes bilaterally. So here's an imaging example of encephalitis. On this T2 and T2 flare sequences, we see hyperintense signal and swelling of the gyri involving the right insula, the temporal lobe, as well as the inferior frontal lobe. And as we discussed in the previous slide, this pattern of enhancement is concerning for herpes encephalitis. Herpes encephalitis can be rapidly fatal if not treated with antiviral medications. The next entity that we'll cover is an intracerebral abscess. Etiology can be post-traumatic, post-surgical, can be due to extension of a surrounding infection, and can be due to hematogenous spread of bacteria, in which case you tend to see multiple intracerebral abscesses. Organisms that are implicated, so these tend to be polymicrobial. However, most commonly you'll see Strep viridans and Staph aureus. In terms of pathophysiology, this is due to contiguous or hematogenous bacterial seeding of the brain parenchyma, which causes the formation of a walled-off abscess. This can have mass effect, causing compression of the neural structures, leading to neurologic compromise. Classic imaging findings are those similar to that we saw with epidural abscess and subdural empyema in the previous video. With an abscess, you tend to see peripheral enhancement, that outer rim of enhancement, as well as central diffusion restriction, which as a review appears bright on DWI and dark on ADC. So here we have a few representative images of an intracerebral abscess, in this case involving the left cerebellar hemisphere. We see some of the classic findings, including peripheral enhancement, best seen on the T1 contrasted sequence on the right, as well as central diffusion restriction, appearing bright on the DWI and dark on ADC sequence. So far we've covered infections of the cerebrum. Another anatomic structure that can be susceptible to infection in the intraaxial compartment are the cerebral arteries themselves. And one process that we'll cover here is called an intracerebral mycotic aneurysm. It's a bit of a misnomer because mycotic may make you think of a fungal infection. However, this is most commonly due to bacterial infection. And the etiology is bacterial seeding of the intracerebral arterial wall. And importantly, this is due to spread of the bacteria via the vasovasorum, which are the small vessels that actually supply the vessel itself. Organisms that are implicated most commonly is Staph aureus, commonly seen in cases of patients who are bacteremic or have endocarditis, in which the bacteria is spread via vegetation on the heart, and septic emboli will migrate via the vasovasorum to the intracranial arterial wall, and commonly this is seen in the distal MCA. This process results in a focal arteritis or inflammation of the arterial wall, which causes it to weaken and causes the formation of a pseudoaneurysm or dilation of the arterial wall. And these aneurysms are weakened, they're susceptible to high arterial blood pressures, and this can cause rupture of the aneurysm, which can be catastrophic, can manifest as subarachnoid hemorrhage or intraparenchymal hemorrhage, which can cause rapid neurologic compromise and can be fatal. Classic imaging findings for intracerebral mycotic aneurysm. On CT, you may see complications of rupture of the aneurysm, such as subarachnoid hemorrhage bleeding into the subarachnoid space, or intraparenchymal hemorrhage located in the lobar distribution. It's reflective of a common location for these aneurysms to form at the distal MCA. Also on CTA and DSA, which are imaging modalities that better visualize the vessels themselves, you can see fusiform dilation commonly located at the distal MCA branch points. So here we see some imaging examples of a mycotic aneurysm, in this case rising from a branch of the right M3 segment of the MCA. And we see this sort of balloon-like dilation of the vessel wall, consistent with mycotic aneurysm. Here we see some images showing examples of infectious CNS vasculitis, which very similarly to intracerebral mycotic aneurysm is due to bacterial infection and inflammation of the arterial wall. And some of the classic findings we see here are sort of bead-like appearance of the vessels. We see this most prominently on the left MCA, where there's a focal narrowing followed by dilation, followed by another area of focal narrowing of the vessel wall due to segmental inflammation. We also see that this is associated with hemorrhage located within the left basal ganglia due to weakening of the arterial wall by the infectious process. So next we'll cover infections of the cerebellum. These are termed cerebritis and rhombencephalitis, similar terminology to that used for cerebritis and encephalitis. Cerebritis is typically used in the context of post-infectious cerebellar inflammation, whereas rhombencephalitis is commonly used in cases of bacterial, viral, and paraneoplastic processes causing inflammation of the cerebellum. Pathogens that are typically involved tend to be listeria, can also be seen with enterovirus and herpes viruses. Pathophysiology involves the contiguous or hematogenous spread of the pathogen to the cerebellar parenchyma. This causes inflammation of the cerebellar parenchyma, which impairs the permeability of the blood-brain barrier and causes a high risk of hemorrhage as well as abscess formation. Imaging findings, best seen with the T2 flare sequence, you will see hyperintensity and edema of the cerebellar gyri. So here are a few images showing some of the representative findings seen in cerebritis. On these images, we can see, particularly in the T2 flare sequence, bilateral, patchy enhancement of the cerebellar hemispheres. We also see enhancement of the cerebellar folia bilaterally, best visualized on the T1 contrasted coronal sequence on the right. Here we have representative images showing a case of rhombencephalitis in a patient who had listeria infection. We see arrows indicating on the T2 and T2 flare sequences areas of hyperintensity in the left pons and left cerebellar hemisphere. And we also see on the follow-up CT on the right-hand side hemorrhage located within the pons and cerebellum resulting from complication of this infectious process. And to conclude the video, we will cover infections of the spinal cord. It's typically referred to as infectious myelitis. Etiology is due to disseminated infection, classically in patients who are immunocompromised. Pathogens that are implicated tend to be herpes viruses, but can also be seen with mycoplasma, TB, and syphilis. The pathophysiology involves either bacterial or viral infection of the spinal cord, causing inflammation of the spinal cord and neurologic symptoms. Classic imaging findings, you tend to see hyperintensity on the T2 sequences located within the actual spinal cord parenchyma with cord edema. So here we have a couple representative images of myelitis. This is a patient with HSV myelitis who had AIDS. We see on the left-hand image this long segment T2 hyperintensity located throughout the cervical spinal cord. And on the right hand axial image, we see evidence of cord edema, both consistent with the findings seen in infectious myelitis.